Today we're going to talk about depression, but I don't want this to be a depressing time for us as we're talking about this. I think this is more of an informative session. We'll talk about different types of depression, some of the causes and symptoms, and definitely we'll talk about the treatments, and we'll have more time at the end to talk about how specifically maybe to apply that to some of the situations some of you may have dealt with yourselves. So, by the way, please ask questions along the way. I would like for this to be more interactive. I don't, I don't want to just talk for 2 hours. That would be boring to everybody and me. So, Judy or Robin, if you guys see any questions in the chat, because I might not be able to see them, just alert me, let me know.
Absolutely.
So that we can address those questions. All right, guys. Well, I guess we can start. So. What is depression? Well, everyone feels sad or low sometimes, but these feelings usually pass with very little time. Sometimes I hear people talk about, I felt suicidal, for example. I had these thoughts about, well, what would happen with my life if it just was over? Like, what would happen to me? Or sometimes they're stressed about something and they start questioning, well, what's the point of all of this? Or I feel like there's way too many things on my plate and I don't know if I can do all of them. Or maybe I'm not living up to expectations that I had for myself or other people had for me. Well, a lot of these feelings are very normal thoughts and feelings that people experience throughout their lifetime. And that doesn't mean that is depression or even depressive symptoms. These are normal thoughts based on the situations that we're in. Now, what actually is called clinical depression is it's considered to be a mood disorder that causes distress and symptoms that affect how you feel, think, and handle daily activities, such as sleeping, eating, and working. And in order for it to be a diagnosis, one must experience this most of the day, nearly every day, for about 2 weeks, for at least 2 weeks or longer. Now, so we're talking about not a depressive negative thought that came into your mind, but rather a feeling that lasts a long time, is significantly affecting your day-to-day life. This is one of the features of Diagnostic Statistical Manual in psychology and psychiatry that people don't know about, is that any condition has to significantly affect your day-to-day functioning, such as, like I said, sleeping, eating, or working, right? If it doesn't, then it can't even be diagnosed technically. I always make this joke, is that if somebody's saying that, you know what, there's a pink elephant running around me and I see him and he's everywhere, but he doesn't bother me. He's kind of funny and cute, and yes, I'm going to work. Yes, I'm going to school and I'm attending to all of my daily routines. Then it can't be necessarily a diagnosis of psychotic symptom, right? So again, the effect of these depressive thoughts and feelings has to affect your overall life for a significant amount of time. Okay. All right, so let's talk about different types of depressions. Now, the most common 2 types of depression is major depressive disorder and what's called, it's a new name, persistent depressive disorder, which used to be called dysthymia. Now, for major depression, one must have, as we talked about, these symptoms for most of the days, for at least 2 weeks, and they have to interfere with your life. It can be a single episode, or it can be repeating episodes throughout your lifetime. And usually they are repeating, because if the person is not getting necessarily help with depression, and it's contextual, technically depression has about 6 months of cycle that people usually can come out of on their own, because things change in life and they kind of learn how to cope with it better. But they tend to reoccur because the actual issues that are behind that depression have not been addressed. Now, persistent depressive disorder is something that needs to have a longer period of time to pass before it can be diagnosed. We're talking about 2 years, but it is definitely less in terms of its intensity. If you think about the amplitude, about the waves, of how intense the depression can get, well, dysthymia has lower amplitudes, so less less effect on your life. You can still function, but you're just going around and you're feeling down and sad, and yeah, you can function, and it's kind of coming and going, and you have these very frequent waves from sort of feeling normal to feeling down for this very long period of time. And actually, you know, most of the time, the clients that I see, they don't necessarily have the full-on major depression, but they do experience dysthymia, or what's now called persistent depressive disorder. There's some other forms of depression that I should mention. There's perinatal depression. Is basically for women who are carrying a child. They can experience depressive symptoms in the process of the pregnancy, and then also after the delivery. You guys probably heard that term more often. It's called postpartum depression. Another fairly interesting condition, it's called seasonal affective disorder. It's basically depressive disorder that comes and goes with seasons. And anybody want to guess what are some of the seasons that most likely will cause seasonal affective disorder? Oh, it's on here. Never mind. We're not going to go there. But basically, for example, this is why people say that there's a lot more cases of depression in Seattle, because there's not enough sunshine there. There's a lot of clouds, a lot of rain and overcast, and so without that vitamin D that we all need from naturally, that we get naturally from sunshine, a lot of people who are prone to depression will experience seasonal affective disorder. Similarly to, for example, England, they also get a lot of rain over there. So in any places in the world that get more of this overcast will have more of these cases of seasonal affective disorder. In California, I think we're lucky. We don't necessarily have a lot of that happening here, but it does happen. You know, some people in the wintertime will definitely, even here in LA, will experience some of these symptoms, and they will be very cyclical. Psychotic depression is definitely more problematic. It's usually very severe depressive symptoms that are accompanied by the psychotic symptoms, such as delusional thoughts or sometimes even hallucinations. Definitely usually warrants psychiatric support first, and then therapeutic support after that. Frequently people end up in a hospital, not necessarily because of depression itself, but rather because of some of these psychotic features, because they're more disturbing sometimes than the depressive symptoms themselves. Fairly dangerous condition too, because a lot of times in these situations, those hallucinations or delusions can be strong enough for a person to possibly impulsively act out. So this is definitely a one that needs to be addressed immediately. Not something you want to wait for 6 months to go away. There's some other types that are less likely to be seen. One that was recently actually added is disruptive mood dysregulation disorder. It specifically talks about mood, but it's mostly diagnosed in children and adolescents. And if you wanted to kind of label what it looks like, it's mostly volatility in these young kids and adolescents. They don't, I'll come back to this later, but usually teens and young adults and kids, they don't express depression in the same way as adults do. There's no sadness. There's no, not as much sulking going on. There's no crying. There's more irritability, anger, and sometimes worries and cleanliness in younger children, or difficulties with separation anxiety. And that could be a sign of depression. And therefore, this disruptive mood dysregulation disorder was added specifically for that. Which is actually really interesting, because we do see a lot of that for individuals on the spectrum because of general emotional dysregulation. And so it's sometimes you can get misdiagnosed with disruptive mood dysregulation disorder, even though those emotional and mood swings are just part of the spectrum sensitivity, emotional sensitivity. There's premenstrual dysphoric disorder. Women do, because of the changes in hormonal balance. There's some women experience fairly significant depressive symptoms during that time. sometimes parents and young adults bring up the question about bipolar disorder, describing somebody who is kind of going from these ups to downs and frequently cycling through that. And I always try to remind that the actual definition of bipolar disorder is mostly depressive states. And so this is why it's on here that depression can be part of a or phase of a bipolar disorder that is long lasting. Let's say throughout the year, a person is mostly depressed, and only so often, maybe 2, 3, even 3 times a year is fairly rare, they have these manic episodes where they go into this, extreme state of elation, um, high energy, no sleep, sometimes even, which leads to hallucinations and delusions, because if you don't sleep, you will start experiencing psychotic symptoms. And so that is a very different kind of depression, even though the treatment is fairly similar in terms of medication and therapy. The biological underpinnings are somewhat different. So what can cause depression? So, okay, these animations are long. I didn't realize that. Okay. So the research suggests that there's a genetic, biological, environmental, and psychological factors playing a role in depression. So it's very, very difficult to decipher sort of which one is which. And frequently, depression can be related to some health issues that are more chronic in nature. And we see a whole separate line of work and therapy for those who have these more long-term medical conditions, because there's truly something that's going on with them, and it's realistic. It's not some kind of a distorted view of reality that they're dealing with. There's an actual factor in their life that can significantly affect their life expectancy and quality of life. So it's a different type of approach to deal with those individuals. And by the way, depressive symptoms of depression itself, because of the stress that it puts on your nervous system, can add to these medical conditions, and so it creates this cyclical process. So very, very important to, especially with elderly as well, those who begin to experience all kinds of additional medical conditions, not to dismiss the presence of depression. A lot of times, elderly will not talk about feeling depressed. They will express it in different ways. And some medications can also contribute to depressive symptoms. Again, talking about elderly who take a lot of different medications for their health issues, can actually sometimes even cause the state of delirium, which can be, partially depression, partially psychotic symptoms. So it's very important that the doctor who is treating individuals with those medical conditions is paying attention to comorbid depression. Okay, so let's talk about some of the symptoms of depression. What does it actually look like? So persistent sad, anxious, or empty mood, feelings of hopelessness or pessimism, feelings of guilt, worthlessness, or helplessness. So actually, the 3 pillars of the depression, it seems like, in terms of thought process, are hopelessness, worthlessness, and helplessness, right? When the person gets to the point where they feel that there's no hope to change the situation, and they have no control, no locus of control over whatever is happening to them, they begin to experience these feelings of helplessness as well. And part of that, or the root of that, could be the feelings of feeling worthless about themselves, whether that's the cause and that leads to hopelessness and helplessness, or as a result of them not being able to change the situation, they can start feeling worthless as well. And so those are usually the 3 pillars that hold depressive states solid. And so when you try to work with clients in therapy, these are the main issues to address in terms of therapeutic cognitive therapy and therapeutic approach. There's also an experience of loss of pleasure, what's called anhedonia, where people stop experiencing pleasure from things that they usually enjoy doing. Okay, it does not mean, like, for example, if somebody does not want to play the same game that they used to play before, that they're depressed. that doesn't work like that. I think it's more generalized. For example, you don't enjoy eating food, or watching TV, or going bowling. If that's what you used to love doing, you just don't get the same amount of pleasure from that. It's frequently associated with decreased energy, fatigue, feeling slowed down. A lot of times clients will report that even after they wake up, they feel fatigued, like they don't have energy to go throughout their day. And that can lead to issues with concentration, memory, and decision making, right? If decision making, if your cognitive factors are not fully there, it's hard to make the right choice. But also the feelings of worthlessness and helplessness can sometimes affect your belief that you can make the right choices. There's also issues with hyposomnia and hypersomnia. Some people sleep way too much when they're depressed. They can't get out of bed. They're just sleeping in bed most of the day. And some people can't sleep at all. And that, again, can lead to other serious issues. There's sometimes weight changes. If somebody doesn't want to eat, of course, they're going to lose weight. And some people do what's called emotional eating, right? You guys, I'm sure, heard about that. And so that causes them to gain weight. And if you think about it, it creates further cycle for the reasons for them to feel depressed about themselves. Of course, the most dangerous aspect of it is the feelings of suicidal ideations and desire to end all of this, because if you feel like there's no hope, how can you live in this state of mind all the time? And so this is definitely when people begin to either hopefully seek treatment, or at least some kind of a psychiatric medical help to address that particular symptom. In young people, there's some more of restlessness and irritability. And in a lot of cultures, we see that expression of depression can be not in psychological symptoms, not in the symptoms we talked about, but because of the taboo of mental health issues in general, they will create what's called psychosomatic symptoms, right? Where they will rather complain about pains, like stomach pains, headaches, cramps, digestive problems, and any other sort of medical issues, rather than talk about the actual emotional states, psychological emotional states, because they feel like they can get support from people if you have medical problems, because that's normalized in most cultures. But if you have psychological issues, that could be looked down upon, and so they don't dare to express that, and therefore we see a little bit more psychosomatic symptoms in those cultures. For example, in Asia and Latin America, that is very common. But it's not like it can't happen here in the United States as well. Okay. I don't know. I saw some text chats. I don't know if there was a question or not. No? Okay.
No, there's no questions yet.
Okay. Now, does the depression look the same for everyone? Well, the answer is no. We definitely know that women have actually have more frequency of depressive symptoms than men do. It's possibly because of the biological reasons related to the life cycle and hormonal factors that affect women. And even the symptoms could be a bit different. Like I said, for example, sadness and worthlessness and guilt can be more common for our females. And for men, we definitely see a different type of depression where they express it through sometimes anger, because again, it's not societally acceptable for men to sometimes talk about how they feel. As we talked about cultural differences, there's also gender differences. And so this anger and irritability is shown because they need to express that intensity that they experience inside. And also the more of the medical symptoms we begin to see surface as well for men than women, with the misuse of self-medication such as drugs and alcohol. And it's very common that men that actually they don't recognize that they're depressed and they don't seek help. And we also know it's not on here, but that men usually, when they get to the point of suicidality, men commit suicide less frequently, but they succeed more than women when women attempt suicide, which means that they're using more lethal ways of doing that. But again, that's just to show that there's a difference in gender in terms of how this depression is experienced. We talked about older adults, so I'm going to skip that. We also talked a little bit about the younger children as well. A lot of times children will refuse to go to school. They'll try to stay more with the parent and express some worries, or they just project their own worries of, for example, death on their parent rather than talk about themselves. This is younger children. Teenagers, as we talked about, show more of irritability, anger, sometimes opposition. We see some of the eating disorders begin to surface, definitely substance abuse, and some other less effective ways of expressing yourself, such as cutting behaviors and so forth, frequently are misused with depressive symptoms because they read somewhere online that, you know, when you're feeling bad, that this is a thing to do, when in reality it actually is not something that would help with feeling depressed. And cutting behaviors are mostly associated with borderline personality issues, which is a completely different condition and completely different feelings and experiences than depression. So again, sometimes internet could be really problematic when people start just Googling things. All right, so let's talk about treatments for depression. There's definitely a lot of research that has been done on depression. We're talking about close to 60 years now, if not more, in terms of specific treatments that are research-based. So there's definitely a lot of medication information out there. There's psychotherapy, and there's certain brain stimulation treatments that are available. Self-help is also a common way of dealing with depression for a lot of people. A lot of people don't go necessarily to see a therapist because they feel like they can handle it on their own, but they still need some support in terms of knowing what to do. And so you might as well just throw it out now. It's not on here, but you guys can make a note of an excellent book by David Burns. He's a psychiatrist he's at Stanford, really brilliant man. He wrote a book called Feeling Good. I think it's like $7 or $8 on Amazon. So if you'd like to get that book, and if you're looking for some self-help skills and support, it's really easy read. He writes it in a way that it's really easy to understand. There's no confusion behind it. And he actually did some studies where he just gave his book to patients who were depressed, and then he had a control group. And he saw that those who read his book and did what the book was asking for, without therapy, showed significant improvements in comparison to the control group. So sometimes these self-help books can be really, really, well, helpful. All right, just a little, you guys can read this this note later, but basically you have to make sure that whoever is prescribing the medication for you is knowledgeable, and they will explain all of the side effects and other possible bad interactions that can happen with antidepressants. So make sure that the doctor is supervising you. And sometimes people go to their primary care doctor to get medication. I think when you experience symptoms of depression, I think it's much better for you to seek support of a psychiatrist at that point to make sure that they monitor your symptoms and prescribe medication. There's a lot more training that they go through in that. They should be up on most recent research, and your primary care doctor might not be focusing on that or specializing in that. So I wouldn't necessarily go to the primary care for that. And I see this happen a lot. I think maybe it saves people some money or time. But if you are dealing with serious depression, it's best to seek support of a psychiatrist for medications. Okay, so let's talk about the kinds of medications that are out there for this. There's 3 different types. There's tranquilizers, there's antidepressants, and mood stabilizers. Tranquilizers, there's 2 different types. One is what's called, they usually are in the category of anxiolytics. They're prescribed for anxiety, but in certain really intense states of, let's say, anger or irritability, they can be helpful. And so they're taken as needed. They're not taken on a regular basis. They're not going to cure your depression, but they will help with the intensity of the feeling that you may be experiencing in that moment. If somebody's like really angry and they can't calm down, something like Xanax or Klonopin, which is part of the benzodiazepines, can be helpful. Now, you got to be very careful because they can be addictive, and that's why you don't want to overdo it with them or take them outside of the protocol of prescription. Then there's another class of major tranquilizers, which are called atypical antipsychotics, and they are more commonly used for melancholic depression and psychotic depression that we talked about before, as well as for someone who has acute suicidal states. So, for example, when somebody is going or commonly expressing suicidal ideations, either Abilify, Risperidone, or Zyprexa will be prescribed. If somebody ever shows up to the psychiatric unit and is hospitalized, they will for sure prescribe an antidepressant. So, like I said, so the Abilify and Risperidone would be used in combination with antidepressants to create the fastest improvements in some of the acute depressive states. Abilify and Risperidone has also been approved for treatment of autism-related symptomology. So it's very interesting that it could be also helping with depressive states. And for those who are taking these medications for other reasons, there's a possibility there's some protective factor from experiencing some of these drops in your mood. Okay. Okay. Let's see. So in terms of the actual antidepressants. You guys heard about the concept of SSRI, right? Selective serotonin reuptake inhibitors. Basically, the biggest postulate of depression from biological perspective is that there's decreased amount of serotonin in your synapses, which causes you to experience depressive symptoms or sometimes even anxiety. It's the same postulate. So what these antidepressants do is that they prevent serotonin from being reused by your cells quickly, and it just allows for serotonin to stay in those synapses longer, which technically should improve the feeling, these depressive feelings or anxious feelings, and that's their major. It is the major way that they work. Now, there's also something called SNRI. It's not on here. It's less frequently used for depression, but sometimes people use it because there's an additional factor of not just serotonin, but also norepinephrine that helps to have a more uplifting mood. So, for example, Wellbutrin, you might have heard about that. That would be SNRI. Tricyclics and MAOIs, they're definitely, they have a broader action in your system, but they're old school medications, and so I rarely see anybody getting tricyclics or MAOIs prescribed because of the significant side effects they have, but they are very powerful and they can work, and they're usually used when other antidepressants from the SSRI category did not produce the results. And there's some really interesting dangers. For example, when you take MAOIs, like you can't have certain cheeses, you can't have certain wine because interactions can literally be deadly. So there's some dangers of that. So mood stabilizers can be good for the bipolar disorder and the depression related to that. And there's three most common ones. There's lithium carbonate, sodium valproate, and carbamazepine. The problem with them is that you usually don't want to use those unless somebody really has significant danger of going into these hypomanic and manic states, because there's, again, really just a lot of side effects. With lithium, for example, you have to make sure that you go get your blood tested frequently because there's toxicity that comes from lithium. So, but they can be very helpful for certain people. So let's talk about psychological treatments, and this is something I'm definitely a lot more familiar with and have a lot more experience with. We've talked about cognitive behavioral therapy as a main approach for anxiety, for anger, for depression. The reason why we talk about cognitive behavioral therapy more than, for example, psychodynamic or psychoanalytical approaches is that cognitive behavioral therapy is much easier to use in the field of research behind these treatments to see the effectiveness. It's easier to replicate. So we know that, you know, if this certain approach is implemented, then we know that these are the results we can expect. Versus psychodynamic and psychoanalytical approaches, they're much harder to study, and there's much less support because of that for some of these treatments. Doesn't mean that certain psychodynamic approaches can't work, but it definitely is less likely to see evidence for it. There's also mindfulness and meditation that can be helpful for depression, and interpersonal therapy. I added religious counseling here because there's a large group of people who do feel better talking to somebody who is representing their faith and who can sort of talk to them and help them understand the world around them through the lens of their religion. And so religious counseling can be also of help, or can be a good sometimes supplement in certain situations. But in certain situations, it can actually interfere with, let's say, the CBT protocol. Not because CBT has something against religion, it's just they work very differently in terms of what is expected of the client, okay? So cognitive behavioral therapy is this little triangle. We've talked about this before. This is our third workshop, and so I've talked about this in previous two, so I'm not going to spend too much time on it. But again, the concept is that your thoughts lead to certain feelings, and which further lead to a certain behavior. And the only real place where we can change things in therapy is your thoughts. And we then later can maybe attack some of the behaviors, but the feelings is an outcome, and therefore we don't, you know, ever say that the feelings are wrong, or you shouldn't feel sad, you shouldn't feel down, you shouldn't feel depressed. It is more about how you think about the events around you that will dictate how you will feel, and definitely how you will act based on that. So we talked about some of the pillars of depression. We talked about hopelessness and helplessness and worthlessness. And so one of the common feelings or people have about themselves is this feeling of worthlessness. And they also don't feel like the world around them is manageable, right? And so those thoughts will lead to the feelings of depression. Now, what CBT does, it helps people see how they can control their thoughts, which will in turn affect how they're feeling. And it can teach the person how to change the way they think, create what's called cognitive restructuring within their thought process. And by the way, as I said, many people experience depression and depressive thoughts. Not many people go down into the depression that is deep enough to receive a full-on diagnosis. And the reason for that is not because those people are stronger somehow, individuals, or they don't have biological underpinnings for it. It's because the way that they think about what's going on with them protects them from going into these deep states of anxiety or depression or anger or whatever that may be. And so this way of thinking can be learned and taught. And this is what CBT is about. So when you go through the process of CBT protocol, you will learn how to change the way that you think about life, which will protect you further. In comparison to medications, for example, you can take the Prozac, for example, as an SSRI, and you will see a decrease in symptoms. But the problem is that as soon as you stop taking Prozac, the same symptoms will return because nothing has really changed about the way that you react to your environment and react to what's going on in your life and how you think about yourself. So you can think of a medication as a band-aid, so to speak, on the problem, and therapy is the actual, as they say, I guess, cure for it. Now, in terms of the outcomes, of course, it's much better to do both together. You prescribe medication and you go through the CBT to get the best treatment outcomes. And the reason why you would want somebody on medication while they're going through CBT protocol, because it's not easy to go through therapy and do some of the exercises that the CBT therapist will give you. So you need some biological support there, and that's why medication can be helpful to give you that support. So if, for example, I'm asking you to reach the ceiling and you just can't physically do that, no matter how much I'm coaching you to do so, you may need a little bit of a step stool to reach that ceiling, and that step stool is the medication, but the rest in terms of how do you reach the ceiling is a part of therapy, if that makes sense. Now, again, there's always some people who don't necessarily benefit from treatment, and it could be drug resistant depression, treatment resistant depression, and you know, at that point, some other methods of treatment will be necessary. In terms of mindfulness meditation, mindfulness is about being aware of what is happening in the present on a moment-by-moment basis, while not making judgments about whether we like what's going on or not. One of the reasons why mindfulness meditation that brings you into here and now works well, sometimes even in conjunction with CBT, is because if you think about it, a person who is depressed, they frequently are spending way too much time in the past, thinking about what they should have done. Like the word should or should have is the most common distorted thought that individuals with depression experience. And the more you think about the past and what you should have done, how you should have lived your life, or what you should have done in a certain situation, the more you're going to get depressed, because of a very simple reason: you cannot change the past. And so the more time you spend there, the more depressed you're going to get. Sometimes people who feel hopeless, they spend a little bit more time also in the future, like predicting how things will unravel, and sort of engage in future telling distortion. And that also is problematic because you don't know what's going to happen in the future. There's way too many variables in our world that can create changes in your life that would be fairly drastic. You can win a lottery tomorrow, or we can have another pandemic, right? You know, nobody was expecting pandemic, and well, here it is, right? It would have, the chances were astronomically low for it to happen, and yet here we are living with it in the rest of the world as well. So that's why mindfulness meditation can bring you into the moment-by-moment basis, so that you only focus on here and now and how you can experience that moment better, okay? There's also interpersonal therapy, and actually I think it's very important, especially for those on the spectrum, and I frequently have to combine both CBT and IPT together to create changes in somebody who's on the spectrum who is depressed, because we see a lot of times that depression in people is related to their difficulties or vulnerabilities around social functioning. So whether it's work relationships, personal relationships, friendships, romantic relationships, and their personality and how they relate to other people. And frequently, if you help them learn how to change the way that they interact and relate with to other people, it can significantly improve the environment that they're in, and therefore the environment becomes less triggering for their depressive symptoms and becomes much more positive, therefore helping the person get out of this depressive state. And we talked about religious counseling. Okay. So there's some biological treatments for depression. And again, these are usually used more kind of like as a last resort, technically, for depression, especially ECT. You guys have heard about this, probably saw some of the popular movies where they used electroconvulsive therapy. There's definitely problems with it, but when someone is not responding to medication, when they're not responding to treatment, and they're still experiencing very severe symptoms of depression, you have to do something. And so it's not an easy choice for a lot of patients and a lot of doctors to use, but it does seem to have a significant effect on people who are in those very problematic states. The problem with it before, of course, was the fact, you know, people were going through all kinds of extremely painful feelings while they were receiving ECT. But now ECT, for example, they do it at Stanford, they do it here on the West Side as well, in Los Angeles. They know how to make sure that you're not experiencing any kind of discomfort during the actual ECT procedure. the biggest problem for most people is it affects their memory, and so a lot of times people begin to forget what their past, so retrograde amnesia symptoms, but some of them do feel better. And so when somebody can't sleep or eat, you know, or drink or take medications, so that seems to be the only way to go. However, most recently, FDA approved a much more effective treatment for depression that does not have those side effects and seem to be extremely effective for the same group of people who are what's called drug-resistant or treatment-resistant depression. Sorry, that's for the uses of electroconvulsive therapy. The transcranial magnetic stimulation is that new approach. Now, it specifically focuses on stimulating your prefrontal cortex using these magnetic waves that are, you know, the triangular way, stimulate known areas responsible for emotion in people. It's a fairly well-tested at this point approach. A lot of psychiatrists are actually getting these machines in their offices because they feel like this is something that they can actually do that's a little bit more direct than medication that can affect your whole brain. This way, you're just stimulating one part of the brain. Fairly expensive, requires a number of visits. I think it's close to 20 visits at least. But like I said, the results are amazing, and you know, there's hope of generalizing this kind of treatment to other areas of psychiatry and psychology to see if they can be as effective in stimulating some of the areas of the brain that show lowered activation. When you talk to people who have done this, they talk about this feeling when they're in this machine as if somebody's just like, you know, using their finger and hitting them on their skull like this. It's not very painful, but you know, when you're sitting there for half an hour and it's the same kind of feeling of knocking on your skull, it can get annoying at least, and maybe be a little bit sore after that. I think it's kind of a similar concept to Chinese water torture, if you guys know what that is. But anyways, it's less invasive, obviously, than ECT. The side effects are, like I said, the only some soreness in that area where they use it. And if it has an effect, it has a fairly lasting effect on the person. So some people even sometimes think that they want to do this instead of the medication approach. But again, even if you reactivate the area of the brain that is hypoactivated, but there's a significant distorted thought process behind it, you still have to go to therapy. That's why any of these biological treatments may address some of the biological and genetic underpinnings, not even genetic, just biological underpinnings that could have root in genetics. But the thought process has to change. Otherwise, like I said, it becomes a band-aid that you will have to change because, as they say, the wound will continue to bleed, okay? Oh yeah, and insurance companies are paying for this as well now because it was FDA approved as a effective treatment. So if anyone is ever interested, you might want to find people who do that in the community. Now, we talked about self-help. I think it's very important to understand that, and that image kind of summarizes it for you. You have to start forcing yourself to think differently about what's going on in your life. So, and also start being have more realistic expectations of self, realistic expectations of the environment, of people around you. And so these are some of the ideas in terms of self-help goals, self-help bullet points one would want to address. One of them is setting realistic goals for yourself. You know, I can be very depressed right now too if my goal was, for example, to be, I don't know, an astronaut, right? I'm clearly not on Mars right now, or will be on Mars anytime soon. Well, maybe one day. But point being is that I'm not an astronaut, and so I can be very depressed if that was my goal, but it's a fairly unrealistic goal for myself. And so setting more reasonable goals can really help with feeling less depressed and less worthless about myself, okay? um, breaking some of the large tasks into smaller portions and knowing how to set priorities. So, for example, some people feel really bad about their college career or college process or their work, and they feel like they should be at a whole different level, and they know how many steps it takes to get there, and they become overwhelmed with it and feel like it's hopeless to get there. And so being able to break it down into smaller steps can be very helpful, so you can be happy with every small step that you achieve. And again, especially for my clients on the spectrum, this is very important because of the executive functioning challenges sometimes. Focusing on smaller goals that can be achievable literally maybe on a weekly basis and feeling good about it that you actually achieved that, and crossing it off your list and seeing them go away from your list or being crossed off your list is a really positive emotional experience. Being with other people is definitely important. For example, one of the things that clinicians check when somebody is suicidal is what is their social support system around them. And if somebody is alone and there's not many people who can be there to support them through this process, it's a really, really bad correlate of negative outcomes. And so being around other people can really help you because you can confide in them, you can relate to them, they can be supportive of you. And again, talking about individuals on the spectrum with the tendency to be more isolated, this is a problem. And so this is one of those things that sometimes needs to be reminded to young adults and on the spectrum, for example, that even though you may feel okay being by yourself in your room, it doesn't help your overall emotional state, and you might not immediately know how it's not helping, but the actual feelings of loneliness at some point, whether they express it or not, will settle and lead to more depressive feelings. So being around others is important. Participate in activities that may make you feel better. You know, if you know you love video games and that makes you feel better, you got to play some video games. If you like anime, you got to watch some anime. If you like eating, desserts, once in a while, have a dessert. Don't make it an everyday occurrence, but because then you're gonna have to deal with weight gain. But you go out there and you do some of these things that can actually make you feel better because you know that they do. Mild exercise, going places, it's part of these self-help ideas. Exercise is very helpful in general. And by and large, our population of individuals on the spectrum does not engage enough in exercise. And so, again, they're just missing out on the endorphins that can produce in you, and also improve your self-esteem in terms of how you look and how you feel, which, tying into the worthlessness issues, right? So, again, very important thing to address if you go into the self-help process. Do not expect a huge improvements right away. Just because you're going to start doing some of these things doesn't mean you're going to start feeling great tomorrow, or even in that moment. Maybe, exercise will be actually tedious and annoying in the beginning, but you will begin to feel better as you go through it. So being, again, more realistic in terms of your expectations. This is an important one. A lot of times people, when they're in those states and they feel hopeless and helpless, they start making rash, impulsive decisions about their life, which may actually hurt them later and maintain the depressive states and change their reality to even more problematic. So it's important to always put away any of those important things that you think about doing in terms of drastically changing your life, okay? Some examples of changing jobs, getting married or divorced. Those are not good things to make decisions on while you're feeling depressed, because your thought process about it may actually be fairly flawed. People also rarely just snap out of the depression. It's about, like I said, slow, gradual process. Even though I do have to say that this is more relevant to neurotypical individuals, because what I've seen in those on the spectrum is once they reach a certain level of success with addressing with their anxiety or depression, there does seem to be a switch process, kind of a snapping out of process. So it might not be as applicable to our group, because I frequently make a comparison between my clients' experience with these symptoms as if it's a light switch going on and off, versus neurotypicals, it's more like a light dimmer, right? So if you're feeling anxious, you can lower that anxiety as if you're lowering the dimmer until you almost have none, but it's a slower, smooth process. Versus sometimes when we work on these symptoms, next week a person comes in and says, well, okay, so I'm kind of not dealing with this anymore, so let's talk about something else. Which is great, I think, on some level, because it's almost like they're free of those feelings that don't last and drag them down. And remember that positive thinking will help you deal with negative thinking. And I think the book, the Feeling Good book by David Burns, can be really helpful in terms of that, okay? And allow others to help you. You know, some people who do self-help, they think that they can handle anything, or should be able to handle anything and everything on their own. That's not the case, especially with depression. It's important to have others who are there to help, okay? Now, as I always mention, if we're going to go back to the CBT, these are the 10 most common cognitive distortions that play a role in our negative thinking. So now we're going back to CBT. I just left it for us to discuss at the end, because if we want to spend a little bit more time, it's helpful to have these in front of you. And these cognitive distortions are, by definition, ways that we misperceive the reality around us, or mislabel or misjudge our reality, which will inevitably lead us down the path of some kind of a negative symptom, whether it is depressive symptom or anxiety or anger or anything else within the sort of the negative realm of our feelings. And so it's very important to understand what they are, especially if you're going to be doing some self-help skills. You have to know what you engage in when you get into these in these moods. You have to recognize what your automatic thinking is doing to you, and which of these cognitive distortions are actually part of a particular situation that is affecting you, okay? So really quick, we'll go through these again, and if you'll have questions, we can go deeper into each one of these if you're interested. All or nothing thinking is probably one of the most common things we see for most people, and everybody's at fault in terms of utilizing this kind of distortion. It's kind of sort of this black and white thinking. I'm either, for example, perfectionism is part of that as well. It's either perfect or I failed, right? So there's only two categories. This categorical thinking creates no room for anything in the middle. And if you really think about our world is mostly not black and white. It's not black and white at all. It's mostly gray zone, okay? I always challenge people to come up with something that is just purely black and white, that there's no gray area between that. You know, aside from some of the laws of physics, and even those can be challenged sometimes. Oh, my video froze. Okay, can you guys hear me?
Yeah, we can hear you, Alex.
Okay, just my video froze for a second. Okay, so if anybody can come up with a great example of something that is truly black and white in our world, I would love to hear that, because I have really hard time coming up with one. The only guaranteed thing we know in our lives is that at some point we will die, and even that can be sometimes maybe in the future challenged by our science, right? If we can figure out how our bodies work better. But this all or nothing thinking can be really problematic in depression, and so the person who engages that needs to recognize it and begin to challenge those interpretations and those thoughts, okay? Overgeneralization, when you see, you know, for example, one event in your life and you just apply it to everything. So for example, you went through an interview and they chose someone else, and now you're thinking, okay, I will never have a job, I will never be able to go through these interviews successfully, I will be homeless. So you begin to overgeneralize this one particular event with rejection at work during the interview to every aspect of your life, okay? That kind of overgeneralization is really problematic, because you cannot use one fact and generalize it like that to everything else in your life. It's just will cause a significant domino effect of negative thoughts and feelings. Mental filter is also very common, especially in depression, when somebody will single out negative detail of something that's happening in their life, and they will just focus on that, right? And because they only think about this negative thing, it significantly changes their overall experience and throughout the day, because they're not thinking about anything else other than that one negative event that may actually be true in reality in terms of what happened. But if that's the only thing you think about and you're filtering out everything else, all the other aspects of your life, it really changes the experience and the feeling that a person throughout the day. And so they can add to your depression. Closely related to that is something that's called discounting the positives, is that when you just think about the negative, and when anything positive that happens, you either dismiss it as non-important, you dismiss the chances of it happening again, or just devalue the actual positive experience itself. And so you then only allowing yourself to see the negatives in your life. And I think the best example would be, and I'll just pose it as a question to the group, is when you are, imagine, have you seen those yellow colored glasses sometimes people use when they go to shooting range, you know, those yellow goggles? And if you take, if you're wearing those yellow goggles, and for example, I'm going to give you a line, right? A green line. I'm going to ask you to look at that line through those goggles. What color would that line be? And anybody can answer that. What happens when you combine yellow and green colors?
Orange.
Orange. All right. So orange. I'm not an artist, but it's definitely not going to be. Sometimes people say it's going to be or blue or whatever. It doesn't matter. It's not going to be green because through the filter of those goggles, you're actually misperceiving the reality. Okay. And when you have these these cognitive distortions, they're putting a filter on how you see the reality around you. And it truly does seem realistic to the person who's engaging in this. And this is why sometimes you need to have a therapist there to help them see those distorted ways of thinking. Jumping to conclusions, you know, that you kind of know what's going to happen and you predict the negative outcome. And again, that can lead to the feelings of hopelessness, right? Because you jump into conclusions of what will happen. You kind of predict, right? Magnifications, exaggerating the importance of your problems and shortcomings. Basically, you make them more than what they are, right? So for example, my boss sent back some of the work that I was doing. That's it, he's going to fire me, right? It's more a problem. He doesn't like me, he's going to fire me, you know, and so this magnification continues to slowly but surely, you know, expand. Emotional reasoning is also a very common one in depression, is if I feel a certain way, therefore I am, right? So there's some examples here. I feel terrified about going on an airplane. It must be very dangerous to fly. Do you see how that's a reverse? Should be a reverse, right? You should think about why it could be dangerous to fly, and only then feel terrified to fly. But emotional thinking is the upside down process. So it's very important to stop yourself from emotional thinking to prevent yourself from feeling hopeless and helpless and worthless. We already talked about should statements. I frequently say that should be removed from the English language because it's really, really problematic. It assumes that you were supposed to somehow possess information that you possess now. It's kind of the post-factum thinking, right? After the fact, you know what it is. Well, if you knew this information back then you might have not acted this way. But saying should have assumes that you somehow made a mistake, right? Mistake that you could have prevented, and that's not the case a lot of times. Labeling is very problematic in depression as well. So for example, you know, I made a mistake, and you attach a negative label to yourself of being, well, I'm a loser, or I'm a fool, right? And the problem is that if you start labeling yourself with such negative terms, you slowly but surely chipping away at your self-esteem, self-confidence, and ego, which leads to this feeling of worthlessness, right? One of the pillars of depression. And frequently, these kind of labels are used on self when somebody is depressed. And it's very important not to engage in that, okay? And stop yourself from using those labels, because those labels have a lot of stereotypical connotations that we should avoid, okay? And the last one is personalization and blame, is when you hold yourself personally responsible for an event that isn't entirely under your control, right? So thinking that everything is your fault, or you start, it's basically the concept of internalization, right? You internalize all of the factors that happen around you, whether they're your fault or not your fault. This happens a lot, for example, in people who get depressed about their relationships. A lot of times they begin to say, oh, this is me, I should have done this, I should have done that. And start blaming themselves really heavily in that situation. However, if you think about it, all of the relationships are the dynamic of two people. It is almost not, it's so rare, I don't even think I've ever seen this, that when I had a couple or two people coming to me talking about their relationship, that it was only one person's fault. Is it lopsided? Yes, sure. One person can have more problems than the other, but it's usually the dynamic that's problematic, and both people are responsible for it. But a lot of times people personalize it and blame themselves a lot when that happens. And when people externalize the problem and only blame others, they get angry. And anger is still a symptom of depression. It's just a very different kind of externalized approach to saying, you know, it's everybody's fault. Everybody's constantly causing me to experience these bad things in my life, and that's why I'm not succeeding. And so what's the point if everybody's going to continuously do this to me? The society is horrible, and society is treating me this way. How can I succeed in that? And that's when people start feeling helpless and hopeless. You know, they might not feel worthless, but they definitely feel helpless and hopeless because they know they can't change the society around them. So it doesn't really matter which way you internalize or externalize, and where you place blame. If you do this in one direction without being realistic about it, it will cause you to feel these negative behaviors, okay? And so one of the things you can do to really help yourself if you're going to be engaging, because I want you guys to get something out of this, not just the understanding of it, but also some things you can do at home. And this is one of the most common, one second. This is one of the most common exercises that are done by cognitive behavioral therapists, is that it's called the cognitive thought record, okay? So you basically try to track all of the situations where you triggered, where you feel bad or exceptionally bad or anxious or whatever, or angry. And you try to fill it out as much as possible, so that then later you can go with your therapist through this, and therapist can help you with for example, the last two columns, because some people have difficulty with the last two columns. If they didn't have difficulty with them and they were already engaging in doing the fourth and the fifth column on this record, then they wouldn't feel those negative symptoms. They would counteract their own negative process. But you first track the situation where what happened basically, and the second more important column is, what was your initial thought, or what's called an automatic thought, right? And you write that automatic thought down, and then you think further, if that was true, what were you thinking about yourself, sort of the negative thinking aspect of it. Hopefully in the process, you know, you can also label what are the distortions that are associated with those, with the second and third column, right? So let's say I was engaging in overgeneralization or black and white thinking, or labeling, whatever that is. And then the progress in therapy actually happens when the client is able to try to find evidence for this thinking. And when they actually are unable to find evidence or find counter evidence to that thinking, the actual facts, that will allow them to create a new, what's called an alternative thinking or counter thinking process that will negate the original negative thoughts that produce this feeling. Okay. Does that make sense? So this, and you do this as often as you can so that you can begin to see where your pitfalls are in your thought process. And you get better and better at finding the better evidence for the situation, and then as a result, you find a better alternative thinking that slowly but surely begins to negate the negative thought process. And the goal is that you doing these records multiple times a day throughout the week, and then you will just slowly but surely will begin to do this more automatically without having to write things down. You start doing this in your head, and then more subconsciously or through a more automatic process, your initial thoughts that are produced will be quickly negated by the new alternative thinking method that you have developed. Okay. And the second one, I promised that that I will come back to the concept of doing something about our behaviors. Well, one of the most important things in depression is that a lot of times people engage in this vicious cycle of depression, right? So I don't know if you guys can see this, because I definitely cannot. Can you see what it says there?
Kind of. Vicious cycle of depression, positive cycle, feel low, feel better. It's a little small.
Let me get on my bigger screen. So, so vicious cycle of depression, you're feeling low. The one on the right is you stop doing things that matter to you. And the one on the left is get less out of life, right? So, and the problem is that if, for example, I know that I enjoy movies, but I'm feeling down, so I'm not gonna go because I'm not feeling like doing this. Well, I didn't do anything positive or interesting that could make me feel better, so therefore I'm not experiencing anything good in my life, which will continue to get back and feed into the concept of feeling low, or the experience of feeling low and down. So what behavioral activation is about is that you actually have to break that cycle by doing something that matters to you, certain things that make you feel better or used to make you feel better. And there has to be a flip, because people say, well, I don't feel like doing this. I will do it when I feel better. The difference is that you have to flip that upside down. You don't wait till you feel better to do this. You do this so you can feel better. Because you can wait for months before you feel better and be able to do something like this. So behavioral activation is about forcing yourself out of this cycle by actually and putting yourself in a situation that has a potential to produce some positive feelings and results. Okay. So these are the two probably most important things you guys can do on your own, is doing the thought record and this behavioral activation. You can think about things that would fit into these categories for yourselves. You know, everybody's very different in terms of what kind of things can make him feel better. Some people love gardening, for example. So if you're sitting at home and you're feeling depressed and you don't feel like going out there and gardening, forcing yourself to go out there to your garden and actually attend to your flowers and whatever else you got there can actually help you feel better and produce those positive feelings in you that can help you feel a little bit better to do more things that can continue this more positive cycle of activity. Actually, a really interesting study recently came out that people who do gardening are just as happy as extremely wealthy people. So, you know how people say money doesn't make you happy? Well, you know, it definitely decreases some of the stress in your life sometimes. But they said that if you garden, you know, in comparison to the positive feelings, interestingly enough, people who are gardening definitely were on the same level as people who could access anything that they wanted in their life and have access to all of the pleasures in the world, so to speak. So simple things like that can actually matter significantly to people, okay? All right, guys. So now that we're in a Q&A, and I hope we can have more of a discussion that we've gone through these slides. I'm going to try to answer some of the questions that you guys may have about what we talked about, maybe some things that are more personally related to you. If it's something very specific and I feel like it's going to take a lot of time, I think it's better if we do this through individual contact after the session at some point. But I'll try to make it relevant to everybody.
Okay.
So,
Alex, you may want to stop sharing your screen so we can go into gallery mode.
okay.
And we do have some questions. So one was from Casey. He says, hi, Dr. Gantman, great session. Thank you. Can you offer any advice on how to deal with young adults who are depressed and know it, years of dealing with therapy, meds, etc., but now refuse to pursue help managing the depression?
I'm assuming we're talking about an adult, right?
Yeah, young adult.
Yeah, adult. Okay. You know, one of the most important aspects of success in therapy is the desire for change, right? Somebody who wants to see something improve in their life. And so when somebody's refusing to get help, it is problematic. And I think this is what I see a lot of times parents of young adults that come to me deal with, is that sometimes the young adults won't seek that kind of help that they need. So it's a difficult question. I think the best thing you can do is really try to find whatever motivation they may have to change what's going on in their life, no matter how small that is. You got to find that ray of light for anyone so that they can begin to work towards that aspect of their life that's motivating. Now, I rarely see young adults or adults on the spectrum who have no motivation for things. It's definitely there. You just got to tap into something that is important to them. And through that, you can funnel everything, including getting help, okay? Including, you know, a healthier lifestyle, taking care of yourself better, pursuing certain career paths and whatever, whatever else that we think would be good for them. So it's about finding that motivation, and that could be tricky sometimes, but you know, for example, for a lot of young adults, I say, like, for example, having relationships, you know, romantic relationships are important. You can be a depressed individual and be in a happy relationship. It just won't work. Your depression, your depressive thought process, for example, will affect your girlfriend, and she might not want to be around that, because positivity, you know, is attractive and people want to be around others who are positive. Negativity pushes people away, right? And so if their goal and something that they're willing to work on is to, let's say, start dating and have successful romantic life, okay, so but let's talk about this depressive way that you're presenting with, right?
Alex, are you done with that, or I don't want to cut you off?
Yeah, no, it's just basically, like I said, so you try to find whatever that motivator is, and you try to, like I said, funnel, for example, getting help and getting treatment for it. You also have to figure out why previous treatments were unsuccessful. With medication, just right away, I'm just going to say this. I feel terrible for psychiatrists. They don't know which medication will work for you. And a lot of times people feel like, well, you know, I've tried 5 different medications and the psychiatrist doesn't know what they're doing. It's not like that. This is very different. It's not like treatment for diabetes, for example, that they have to, there's a specific medication that works the best. And so that's what we're going to give you, and that's going to produce results. Antidepressants, because of our different metabolic process, can, for me, I don't know, let's say Prozac will work, and for Judy, Prozac will be absolutely useless, right? And so, and nobody knows which one will work for us. Now, there's now genetic tests that help you figure out which ones will have the most side effects, but those genetic tests don't say which medication will work. And so when you engage in getting help like this through medication support, you have to be very realistic what the plan or what the process is going to be. Same for therapy. You got to make sure if you're going to go see a therapist that they understand, for example, how spectrum plays a role in, for example, depressive experiences or anxiety. And so it's possible that the previous attempts at, you know, getting help were not necessarily as precise as they should be, or expectations were off, or maybe there was no follow-through in certain suggestions. Like, for example, I do have some clients who, even though I make specific suggestions to them that would definitely help, it takes them a while before they actually get to the point of doing something like that. So there's a delay in action, let's put it this way. And without action, there's not going to be change. And somebody just says, well, you know, we've been doing this now for a year. There's been very little change. Well, it might be because the actual readiness for change wasn't there, or the client wasn't motivated enough. So I would go back and figure out why the previous experiences for this particular case for your young adult were not helpful, and try to make sure that you figure out those variables first, and then work on the motivation to change.
Alex, we have a couple more questions, and I actually have a question too. So we'll start out with Savag, who he wants to know the difference between anxiety and depression, and can you have both?
They absolutely can have both, and one can really easily fit into another. So we talked about how antidepressants affect serotonin, right? And now antidepressants are given both to treat anxiety disorders and depression. So they're biologically closely related and psychologically as well. You know, anxiety is mostly fears about the future, right? Fears of what will happen, or, you know, I see a dog and I'm afraid the dog will bite me. It's always in the future, right? It's not like it's happening right now. It may be very close future, but still it's a prediction of what will happen. Where depression is mostly about the previous experiences one might have had and what they should have done about it. And but it can relate to the projections of hopelessness in the future as well. So yes, they're very tightly related, but the feeling is different. When you're anxious, you're worried. And so the physical symptoms of that are different than when you're depressed. Okay, and you can relate to, Judy, is my anxiety PowerPoint up somewhere?
Yeah, the PowerPoint is up, and also the video of the session is up. And so Savag should have received an email, and if he didn't, he can let me know. That is a link to watch that, as well as your CBT lecture.
Yeah, so Savag, if you take a look at that, you'll see the difference in terms of the anxiety and depression, but they are closely related, and you can have both. Most of the time, people who are severely anxious feel fairly depressed as well, because if you're afraid to engage in life, in whatever aspects of your life, but you really know that you want to, or you know you should, it's problematic, because you're then staying away, you're avoiding, escaping all of that, but you know you want that, but you can't get there, and that can be very depressive and self-defeating.
Alex, this question is actually from me. We're living in a really strange period of time. With COVID, you have a situation where there's a pandemic, and it's real, and it's affecting our way of life, and to a point where that can be depressing. And then secondly, and I don't usually get political, but our political environment is very frustrating right now and scary. And it's just different than it normally is. And that also, and both of those aren't things that we can necessarily control. I mean, we can make the best of it. We can create a situation where we can exist with COVID and be safe, but at times it can be overwhelming and depressing. So, and a lot of the self-help are really about more my personal experience and things that are happening to me that are more about the self, not necessarily about the environment. So what's your advice for people that are having coping issues with those two major events that we're experiencing at this moment in time?
So thanks for a hard question. Well, okay, so we got to take those two situations separately. So let's talk about the pandemic situation. In terms of the negative feelings, of the depressive feelings of being forced to stay home more, not having access to some of the things we enjoy, like travel, you know, just going out and being free and experiencing the freedom we usually have. I think it's important to look at the sort of the facts of what's being done about that. Nothing is perfect. Remember, we're not going to go for the perfection of how soon someone should have reacted to this, what kind of things could have, should have been done. That will make you feel really bad and angry, and will lead to the feelings of wanting to lash out. But what's important is to see what's being done. And no matter how you look at it, there's definitely significant amount of effort and money being directed towards vaccines, towards treatments. We know a lot more about this condition than we known before. And so even for myself, I try to remind myself that if you look at the sort of what some of these researchers are talking about and the success of their studies of vaccines, for example, it's extremely promising. And I mean, we've had other diseases that were out there who were just as dangerous, if not even more dangerous sometimes. And now we don't even think of them because we've got treatments for them. And so right now, more than ever, the whole world is trying to work on figuring out how to stop this. So as a world effort, it will benefit the majority of people on this planet to figure out what we can do. And so with that really helps me, at least personally, understand that there's nothing's perfect, but things are being done to bring us back to normality. How soon that can happen? You know, like I said, there's 4 vaccines that are shown to be very effective now. Technically, if we were just sort of gung-ho about it, could be out there, you know, we could be getting those vaccines today. But do we really want to? Like, I don't know. I want to see first if, you know, they're safe and I'm not going to grow another leg or something. But it's being done. Okay, and same thing in terms of the treatments. If you look at the actual research, they know so much now about that, and specific medications that are being developed or used that will address for example, the cytokine storm that causes the majority of issues with lungs. You know, there's definitely a lot of things that are in the pipeline that this cannot be a very long process. It's already too long, but long is an abstract definition, and so you got to look at the facts of what's being done and how what is the when can we go back to our normal state of being. Okay, and I think it's going to be pretty soon, because like I said, it's in the best interest of, politically speaking, economically speaking, and you know, just in terms of our psyche and our humanity. So that helps you, if you look at the facts and what's about to come, that gives you some positivity in terms of at least knowing that something's being done. If we were sitting here and saying, wow, we have no idea what this is all about, we don't know what to do with this, there's no treatments, you know, what can we do? And we were just sitting here with, you know, our hands in the air. That's not the case. And so looking at the facts really helps. And this is usually what helps with anxiety. And this is what we're talking about here, that if you know the facts, it helps you decrease the anxiety, because we have a tendency to over-exaggerate and project all kinds of fears out there, and use what we talked about earlier as emotional thinking. You know, we don't like what's going on now, and so we have all kinds of feelings, and we try to think that this is going to be the result of things. It's the reverse. Our feelings are the result of what's going on. And as soon as what's going on changes, we're going to feel different. So, like I said, facts in that regard are very helpful. In terms of the political situation, and there's a lot of actually clients who bring this up to me on this whole week. We were talking about some of the things that are going on, especially with the elections and sort of some of the things we see in the world, that some of the stability that we've had is kind of shaky and crumbling in all kinds of different aspects. If you listen to the experts rather than the news, and this is a very important differentiation. Listening to what's being said on the internet, what's being said on social public channels, Instagram, Facebooks, you know, these random people online, can really lead to an extreme thought process, right? And this is what we see. We see polarization of thought in our country, and sometimes even in the world. And because the ideas that are being thrown at us are, we misunderstand the purpose of them. There's a lot of people online right now talking about politics for the purposes of attention to themselves, to their channel, to their program, to their cause. And a lot of times those ideas are more extreme than what they should be in reality. And realistically seeing both sides of the equation and thinking about what happened over time, for example, with our country, you will see that significant changes rarely happen overnight. Okay, it takes time to build things up. It takes time for certain things to unravel. There always has to be somebody who's benefiting from that. You know, somebody said, well, you know, the revolution might be coming. You know, in order for a revolution to occur, there has to be someone who will benefit from that. And usually that someone is who is paying for that revolution. If you look at the revolution in France, revolution in Russia, it was always paid by some kind of benefactor that would benefit from that occurrence in some way or another. Okay, there's no evil geniuses out there who are doing this just to be evil. And that's important to also remember. And at this point, personal opinion, if you look at the politics, I think both camps benefit from keeping things status quo. Nobody wants the breakup of the United States. It wouldn't benefit Democrats. It wouldn't benefit Republicans. So it doesn't matter where you are politically. I think the goal is to maintain the United States as united as a country, because that's how we have our power in the world, economically and politically speaking. So if you listen to the extremes, you will hear all kinds of possibilities. There's all kinds of things that are happening, but you have to get away from the news as your source for your thoughts. You have to process the information, and you have to think about it analytically and critically. One of the things they teach you in college is critical thinking. And this is very important. We sometimes get very emotional about things we hear and we forget about the critical thinking process. And so what helps is to look at the data, look at what can be done, and look at the facts. And when you do that, you begin to see that the extremes are unrealistically ridiculous. And so the truth is somewhere in the center, and the truth is frequently on both sides of the equation.
Okay. Thanks, Alex. Sorry to take you down there.
No, but it's a very common thing that I hear right now, and
Yeah,
it causes people to feel depressed.
It's a strange time. Beth had a question about CBT. She wants to know if you're successful with CBT, can you eventually come off of the medication?
Well, that's the goal, right? So we start with medication and CBT. We work on all of the identified negative thoughts and feelings associated with that. And once the person is significantly improved in terms of their ability to quickly attack the negativity, and things begin to, as a result, change in their lives, right? Sometimes there's contextual depression issues. Let's say somebody's unemployed, but because now they take a different perspective on how they go through interviews and how they feel about themselves, and maybe took some other steps to improve that situation. Now they have a job. So things that really were problematic begin to take care of themselves through this CBT work. Then when you're in a good place and you feel like things are going kind of really well now, not because I feel well, but because they actually are better, this is when you begin to come off the antidepressants, because there's really no need anymore for that kind of biological support. So there's definitely a progression of that. And yes, you can get, you should get off the antidepressants at some point.
Okay. Alex, there's some questions about more recreational medications, alcohol and marijuana use. Are those helpful?
Alcohol is actually very dangerous for those who are depressed. People think when they drink, they're going to feel better. In reality, they're not. It worsens the depressive feelings. Alcohol is a disinhibitant, right? So it creates disinhibition. So you don't hold things back. You just let your pure sort of unfiltered emotions out. And when your emotion is depression, this is when people can do something really dangerous and really problematic. And then drinking itself, I mean, it causes you to feel worse in the morning when you're withdrawing from alcohol. It may prevent you from being able to do certain things. It can create problems in your life, like DUIs and so forth. So it can actually add to the contextual depression for you and the physical depression, because you're constantly in a state of withdrawal, right? So alcohol is a definite problem with that. And so whenever somebody is drinking and they're depressed, one of the most important things to work on is quitting drinking. And that could be a whole different story. Now, other drugs, it depends what we're talking about. If you're self-medicating with weed, technically what weed does is it doesn't help you feel better. What it helps you do is escape the reality. for an extended period of time. So there's some people who, you know, as they say, wake and bake, right? You know, it means you wake up and you start smoking. You smoke throughout the day, so you basically escape the whole day, being in a state of intoxication. So yeah, you might have gotten through your day and it was easy to get through your day, but you didn't do anything because while you were so high, you can't change anything about your life. So if it's contextual depression or thought depression, you're really not working on anything. And as soon as you stop smoking, well, all those feelings will come back. So it's not a successful way of dealing with the depression. Can it give you an escape? Sure, but escape is not, it's not going to solve anything. Now there's some talks now about more serious drugs like for example acid or other hallucinogenic drugs that are being looked at on a scientific level. And technically there's definitely some promising things in terms of, for example, microdosing of acid when you're not taking it to get high, but rather you basically have a dose day when you take a very small amount, not that gets you high, but rather creates a biological change in your brain. And then there's 2 days after, which are called the afterglow days, where people who have been depressed frequently report that those afterglow days are the best days that they've had so far. And it's not because they're high, because the drug is already out of their system, but this afterglow is a result of what scientists are talking about, almost like a reset in certain brain areas related to emotion. But again, there's no FDA approval for that yet, but there's definitely evidence that some research labs have produced with that. And I personally have a client actually who's doing that with microdosing, but you know, he's an adult, he's 40 years old, he figured it out, he has a research background, so he's doing it in a very safe way. It can be very dangerous. So I wouldn't recommend anybody to do this on their own. I think it's best to either find a research lab who will help you with that, or a doctor who can, a medical doctor who can somehow guide you through this. And acid is still kind of illegal, not kind of, it is illegal in the United States. So even getting your hands on some of these drugs can add to your depression because you might get caught and then you have to deal with the legal system, and that's a whole different story, right? So again, using drugs, illegal drugs to self-medicate is problematic in multiple ways. But the utility of some of these drugs possibly in the future will be relevant. There's some studies now on PTSD and MDMA, how it can help people disconnect from their trauma. Yeah, so there's interesting things that are happening, and I wonder what will be done about that.
Let's see. Any more questions for Alex? I mentioned that this is the last of our Conquering Emotions series, which I hope everybody found useful. So if you have a question about the previous topics, which were anxiety and anger, that's possible. Oh, we got a couple comments here. So Alex, the other Alex, Florida Alex said, waking up suddenly in a state of panic and anxiety after being asleep for a couple hours, rare but has happened following a high anxiety day. So you mentioned about sleep and its relationship to these emotions.
Yeah, so if you don't have solid sleep, sometimes these feelings can creep up into your sleep states. So, for example, we know that, for example, dreams are expression of your unconsciousness, right? I don't like talking about unconsciousness, but it's that if we're going to talk about sleep states and dreams, that's how it can be. And so some of the things that you see in your dream, you might not even be aware of what they are, can trigger that anxiety in you, and you can wake up in this very anxious state. Or sometimes you are aware of what they are, and you can wake up in an anxious state. Also, sometimes when you have certain issues with breathing during nighttime, like sleep apnea, that can also trigger a feeling of anxiety because you are technically lacking oxygen, and you can go into this hyperventilation state, which is frequently associated with panic issues.
I think Alex did, Morehead-House, do you want to say something?
Not really. No.
Okay. Okay, good.
Okay. This is his mom. Hi, Dr.
Okay.
Hi.
All right.
Hi. Well, actually, this has happened a couple times, almost like a panic attack, but after he's already like gone solidly to sleep, and then come into my room suddenly after 2 or 3 hours of being asleep, highly agitated, kind of not really knowing where he is. And it seems like a carryover from when he's had that kind of day. And it's a thing to calm him down, to make him aware of where he's at. He can see his surroundings. Oh, okay, I'm at home. I'm okay, and go back to sleep. And I noticed that has happened more probably in the last, it was something new probably in the last 5 years. And I thought, uh-oh, panic disorder of some sort. And we got a handle on it, and it seems like just the days being more even more often, which has been really a trend. It's been really good over the last few years. And maybe that's a settling of hormones and settling of maturity in some ways, maybe. Being out in the world more, it has gotten better, but I noticed from time to time, we just probably maybe 9 months ago or something was the last time that happened. And it was a little worrisome for me as a mom, kind of trying to grapple with, okay, is this at the point where it's time to look for medication? What's going on? And then it still hasn't been a pattern. But I noticed that it is after like those really intense kind of roller coaster days, for whatever reason that he's had an issue with something, that it's come to that. And so I was just curious if that was kind of something we didn't really know about it. Maybe it's identifiable. Obviously, the things that we try to do seem to work, and have kind of kept that from being a consistent occurrence. It's like rare.
Yeah. So, I mean, again, if it's not interfering with life too much, that's, you know, I don't know how much effort I would put into actually addressing that. What I think you should address more is the roller coaster days, you know, that may lead to that, because that's, if that is the trigger, right, of all of those emotions and thoughts and feelings, then we gotta address the triggers rather than the symptom itself. Because I think that would be more helpful. Sometimes, you know, when you know that this is the kind of day you had, at the end, going through some kind of physical exhaustion, some exercise can be helpful to put you into a deeper sleep. You know, maybe even if you don't usually take melatonin, taking melatonin to help you stay asleep so you don't wake up necessarily from those brainwave changes. So, but though, again, that's addressing the symptom rather than the root cause. And I think the root cause is truly like, what is it that's setting off Alex during the day and causes him to go through this roller coaster of emotion? So I would focus there more than anything else.
Yeah, Alex, Denise had some comments about, she says, if someone thinks they hear someone whispering their name, is that more of a concern? Her daughter has had the same kind of heart racing from sleep. So I guess hearing voices.
Well, hearing voices as you wake up, or?
Denise?
No, just hearing voices in general. Oh, you got to unmute yourself. Sorry. There we go. Oh.
As she's going to sleep. Oh, sorry. As she's going to sleep.
As she's going to sleep. Okay. So there's something that happens to a lot of people. It's called hypnopompic and hypnagogic hallucinations. So hypnopompic is in the beginning when you're falling into the sleep state, and hypnagogic is, let's say, as you waking up from a sleep state. People experience visual and auditory hallucinations, and sometimes even tactile hallucinations. And that's because your brain is in that semi-dream state, and yet you are, let's say, feeling like you're kind of awake, but then your brain is already starting the dream process. And so that's why hypnagogic and hypnopompic hallucinations are not considered to be psychotic experiences, but rather related to some kind of a sleep cycle disturbance, where one is technically should be asleep, but yet their brain is already in the active state of dreaming. And so that you know, the best thing to do about that is, like I said, making sure that the sleep cycles are okay. You can go to sleep study centers spend the night, and it will record all kinds of brainwave activity in you to make sure that there's nothing that's disturbing that kind of a sleep cycle, or maybe they will make suggestions in terms of the kind of things you can possibly take to improve your sleep and not be in the middle, you know, between awake and sleep states, because that could be disturbing. I had a client who, you know, literally saw a gun in his hand, and he felt the coldness of the metal, and, you know, as soon as he kind of came to himself, it was gone from his hands. But again, this is fairly common. Okay. Sorry, I think you muted again.
Sorry. I also have one more question, which was about EMDR. Did you touch on that?
Well, EMDR is more, it was designed for PTSD, technically, as a treatment approach, right? So, because we were not talking today about PTSD, that's why I didn't really bring it up. Can it be used in depression? Sure, I don't think that's there's significant utility of that. There's other approaches, like, for example, dialectical behavioral therapy, that can be somehow weaved into the treatment as well, to help people sort of connect better with their emotions, because sometimes people can't even recognize their emotions or when they're going in certain emotional states. And so dialectical behavioral therapy can be helpful with that, especially because it's designed for those who have frequent parasuicidal ideas. So I think that would be more relevant than EMDR itself.
Okay, thank you.
I know, Alex, that Josh sometimes has hyper acuity to sound. So he'll hear things, and I'm wondering, and maybe he's just hearing things because he just seems to be able to perceive the sound, you know, say, hey, are we calling him, that kind of thing. Is that common for folks on the spectrum?
It can be. I think, you know, hearing a voice of someone, unless it's repetitive and it's very clear, you know, let's say when he's standing next to you and you're not saying anything, he still hears that voice, right? That would be a problem. Voices that are interacting with you, voices that are commenting on what you're doing, but hearing something in the background, you know, again, when we by ourselves a lot of time, you know, our mind begins to self-stimulate, and sometimes certain even auditory, firing in auditory cortex can happen, and so someone can hear something like that, but they're not sure about it. It's very vague, and they're not really concerned about it because it's so vague and so in the distance that doesn't really warrant attention. Now, like I said, when somebody starts hearing voices that are interactive, or a voice that is interactive or commenting on what you're doing and what you're saying, especially when these are negative statements that you begin to hear, that's a very different issue. And to be honest, for those, there is comorbidity of psychotic disorders and autism. So it is something to be mindful of and pay attention to. But again, if it's taken care of early, you know, it can be handled, but mostly definitely with medication.
Anybody else have, oh, Alex has another question or statement.
His mom, I think.
It says, can you,
Yes, me.
can you, oh, I see. Best way to get a diagnosis for Asperger's, never properly diagnosed.
Well, Asperger's is no longer a diagnosable condition. So we're talking about just getting an autism diagnosis. I think the best thing is to go to any autism centers that will do a full-on diagnostic assessment. I think there's the IQ aspect of it. There's interview with the parent, interview with the young adult, and then just see where he lands in terms of his symptoms. But again, for those who are really high functioning, you've heard about the category called PDD-NOS, right? Pervasive developmental disorder, not otherwise specified.
Specified,
That when somebody has that particular condition, it's really hard to get diagnosed with some of those gold standard autism assessments. So,
well, like, he had a battery of tests at a younger age, and because we were in the military for 25 years, we were never consistently in one place. So fall through the crack, get counselors who knew what was going on. And so we kind of lost opportunities in a way. One thing that he was diagnosed with early on, and I'm going to say it wrong, not echolalia, perlalia or something like that. He repeats. Yeah, and then now that I know what the distorted emotional disruptive mood dysregulation, that definitely was what originally took us to pediatricians and things.
Yeah.
That was Alex's particular challenge that we went through with school.
Yeah.
You know, back in the 90s and before anybody really knew much about anything to do with any of this, really.
Yeah.
So
Well,
we're looking for benefits at this point to try to move forward with some of that, and I'm just kind of lost. We've gone to therapists. You had said this at a meeting when we still lived in California, which is true. You really have to be careful about who you get, because they'll say that they're specialists, but they aren't, and then they don't really help.
right. So yes, again, remember Asperger's came to the United States in 1994. So for those who are a little bit older, you couldn't have even gotten that diagnosis. Even though it came to the United States in 94, it doesn't mean that professionals were even aware of what it is and how to look for it. And so that's why a lot of young adults in their 20s and 30s don't have a diagnosis, really. The benefits of that are, I think, in my opinion, are fairly limiting at this point. If they're so high functioning, they can be really part of the regional center, technically, so they can get those benefits. Maybe they can get help with Department of Rehab.
Yeah, our main thing looking forward is just like, he has no health insurance. You know what I mean? So trying to come up in a way to tie him in. Our benefit of him having a diagnosis is that because we are DEERs enrolled and because of retirees from the Air Force, we could actually get him in back in on our insurance if we had some of that.
Yeah, if you show that he's a disabled adult that is dependent on you. Yeah, well, so you can definitely do that. That would be one.
Yeah, because getting a sustaining job for him at this point doesn't mean it won't happen. It hasn't really happened where and he has a degree and all that, getting into a position where he will get health benefits and all that. So I'm trying to figure out going forward that if that doesn't happen, which is totally fine, you know, how we could better assist him with that particular goal, especially.
Right. So for that purpose, like that'd be good. I don't think you need to get a full diagnosis for that. I've had some parents who were trying to add their kids to their insurance who are over 26, and I think what you really need is just a licensed professional writing a letter support with a full-on diagnosis on that letter. So you don't have to spend, you know, $3,000-$4,000 in doing assessments.
Right.
But again, it all depends on the insurance. So I've never dealt with somebody who has the insurance through the Army. So you might want to, through the military, I'm sorry. So you might
Air Force.
Air Force, there you go. So you might want to find out more about sort of what their particular requirements are in terms of that.
Right.
But the letter usually suffice, or there's some paperwork like I filled out for some people that was enough.
Okay, good. Thank you.
Sure.
Okay, did you see the note from Denise?
No.
So I would like to know if my daughter's magical thinking is related to Asperger's or some other issue, PTSD, ADHD.
I would have to, I would have to know what's the actual magical thinking about, and how deeply rooted it is in terms of her belief system. Because the magical thinking in terms of psychotic process is when somebody, despite the facts that are based in reality, dismiss those and still believe in whatever magical thinking they have. It's something very different when somebody engages in magical thinking as a hope for themselves. And so I guess the difference between psychosis and some of the just hopeful, magical, unrealistic, or not I guess almost immature thought process is one, they truly dismiss the reality, and you know, you tell them the sky is blue and they say, no, it's pink, I believe it's pink, and there's nothing you can tell me about that, it's pink, versus somebody saying, well, I wish that they were pink. That would be so nice, and I really hope one day they will be pink. You know, that's the difference of sort of the magical thinking, the wishful thinking, rather than true delusional thought process. So I guess it depends on the strength and how deeply rooted it is.
Well, Alex, we have just about 2 minutes left. Any final thoughts you want to share?
Again, I would suggest that you try to get the self-help book from David Burns. I think it's just a good read, even for the parents, so you can be a better help to your kids in the moment. Because sometimes when you're in that state, you might not be able to pull that information from your mind. And if somebody comes in there and says, "Hey, do you remember some of these cool ideas we read about in this book?" It might trigger some of their memories about that and help them get out of the funk that they're in. So again, like I said, for $7, it's worth it.
Well, Alex, thank you so much. I think this series was really, really helpful to all of us. And I want to thank all the families who attended. Your support and your involvement has really made this a successful series. If you think of anything else that we could do as a group together, please don't hesitate to let me know.
Thank you guys. Thank you guys for joining us. And please, again, if there are any topics that you guys are interested in, we do have just parent support groups, and you can bring up those during that time. But if there's a more specific and more in-depth topics that you think we should discuss, we can definitely do that. We've done this. We've done many different presentations over our work together with OCASG, and so there's some things that we can just bring back again. Okay.
Okay, so I hope everybody has a great day, and thanks again, everybody, for attending.
Bye, guys. Hopefully we'll see you in person soon.
Bye.
Bye.
More Zoom so I can join from Florida.
Oh, well, thanks. Thank you. Bye.
Bye.